Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help.
Good morning. On today's COVID-related podcast, we brought back Chris Mason. Chris has spoken with us before on the podcast about his work on the microbiome, and most recently was one of the most popular speakers at the Wild Health Summit. If you'd like to catch that talk, go to wildhealthsummit.com and click on the replay button. It's free to watch. Dr. Mason's laboratory builds and deploys biochemical and computational technologies to understand and engineer human and other genomes. He is principal investigator or co-investigator on several NASA missions and projects. Some missions will discern the molecular basis of changes in the human body during long-term human space travel, including genetic, epigenetic, transcriptional, and metagenomic changes. More recently, Chris has redirected all of his research towards COVID-19, and that's what we're going to talk to him about today. Chris, welcome to the podcast. Thanks so much for joining us again. We got a lot of great feedback from the short lecture that you gave us that we cut you off on during the summit. So if you guys missed the summit, you should go check out Chris's lecture on the summit. It was really interesting. He started getting into all kinds of crazy data that his lab's been up to, and I decided we had to get him back on the podcast and talk a little bit more and give him a little bit more opportunity to speak. So Chris, welcome.
Yeah, great pleasure to be here. Thanks.
Chris, so you're at Cornell University right now, although I've been having trouble keeping track with you because it seems like every time I talk to you, you're in a different city. But what are...
I was carrying the coronavirus around, perhaps.
Yeah, right.
Hopefully
that's not the case anymore. I imagine you're staying home. What's it like there right now? Are things as crazy there as they are everywhere else, I assume?
Yeah, so it's been, as most of you, probably your listeners have seen in the news, we are basically at the epicenter currently of the globe in terms of where the most cases are, the most deaths, really the really harshest hit city. We have passed the peak, and I can tell that in a number of ways. So about a week ago, just about a week ago, you would hear not just one or two or even three, but sometimes 4 and 5 and 6 simultaneous sirens around. Like I'd be sitting just with my daughter in the bath, and I'd just stand up in the hallway and listen, and I could hear all around. And I live in Brooklyn, the lab's in Manhattan, and I could just hear, surround sounds, sirens. And it was unbelievable. I've never had that happen in my life. Hopefully never will again, because it was the sound of COVID patients being picked up or people in severe respiratory distress. So it was actually kind of scary. It was like being in a horror movie, like, oh, this couldn't be real. But the weirdest thing was it didn't just happen once or twice. It was basically like that for about 5 days of really at the peak, where it's just constant sirens all day and all night. So couldn't sleep some nights because there were just sirens the whole time. It was really unlike anything I've experienced. And so same with my wife, we were talking about just, unbelievable. And we could see that in the patient data. So at the hospital, we could see, the tick and the number of people being tested kept going up and up and up. And you could see more and more people coming in, going to the ICU. The hospital was, really being, pushed to capacity. And what's good is we managed to, cover all the bases and haven't had to, do anything dramatic, like set up a tent outside or anything. And so the hospital was able to absorb at peak even all the patients coming in, which was great. But it was peak. We had at some point hundreds of tests going through a day. We had other times, if you include the Columbia testing as well, was getting, in the city there were thousands of tests happening per hour at some point. So everyone testing as much as they could. So we're past that point now. You can tell that based on the sirens are no longer. We get maybe one an hour now instead of multiple ones per minute, and so it's really come down. You can almost just feel it because you don't hear it as much, and there's something different in the air. And I can see it from the dashboard at the hospital. We're testing less patients because there's less requests coming in to get tested for COVID, and we're collecting less samples in my lab as well. So it's I think we've just passed the peak and it's going down, and you can hear it and you can see it and feel it even. But it was weird. It's been a weird few weeks, I'd say for sure.
What do you think? What do you think the baseline infection rate is in the population in New York? It's certainly way higher than what we've tested. Do you have any sense as to how high it could potentially be?
Yeah, great question. So this has been an active area of debate because the more we test people, the more we have been able to find it. So, and I can give you some anecdotal data of at least just from our hospital between New York Presbyterian and so I've seen some data from NYU and also some Northwell in the past day that validates and corroborates our results. Is that if you look back about 3 weeks ago, about 1 out of every 3 people coming in who thought they had COVID were testing positive for the SARS-CoV-2 virus. So, it was around, but then basically about a week and a half ago, once it really started, we were getting close to the peak and it started ramping up. 1 out of every 2, or sometimes 2 out of every 3 patients were all positive. So basically, you could just see it in the data. Like basically, the virus is everywhere, right? So the idea of containment was long gone, and so the question of what is the asymptomatic carrier rate? Probably, imagine there's that 8.5 million people in the city. I wouldn't be surprised if like a third of them had it, right? So if the people we're testing, more than half of them have it, then they're with families, they're with friends. A lot of them are asymptomatic, and so we think it's probably in that range. And so that's an ongoing question now for large scale surveillance. Is if we'll know really empirically that answer within the next month as more and more testing ramps up.
Chris, is anybody doing that testing? I know at Gangelt in Germany, they did the serology testing and they found about 15%. And then in the U.S., a couple of large systems have announced big serology testing. Is anyone in New York doing that you know of?
Yeah, we just started. Just talked to some of the directors at Northwell Health System. They're starting to ramp that up. We'll be doing it probably in New York Presbyterian pretty soon for basically people who want to come back to work or healthcare workers. So it's just ramping up, but it's I think it's going to become more common for large employers, healthcare centers, and really eventually anyone who wants to get tested. There's a lot of discussion at the White House task force, plus at the state and city level. Everyone wants to ramp up testing because I think that's going to be the way testing and mapping and surveillance and seeing who is seroconverted. For your listeners, once you've been exposed, the seroconversion is the point at which you actually are producing antibodies from your B cells to defend against the virus. And so that does seem to happen eventually in almost everyone who's exposed, at least from the preliminary data we've seen from a German study. It remains to be seen if it really is close to 100%, or is it in some populations less than that. But hopefully we can do is if someone does have antibodies, much like you think of getting an antibody, if you, for example, any other vaccine, say to hepatitis A or B, and you can say, oh, I've got antibodies I'm still making relative to that virus, we do the same thing here, is do serology testing.
I heard somewhere I think it was from one of the companies that's making one of the serology tests that they were describing like a 90% seroconversion, but I'm not sure that they ever had any like true data to back that or whether that was just anecdotal. You're saying there was a study out of Germany recently that was a little bit more definitive?
Yep. Yeah. Well, it was definitive in that they got to 100%, but it was only about 35 patients, I think. So all of them eventually did, but it's a small sample size. But it was the Wolf et al. Paper just published in Nature a week ago. So it was a small sample size, but it's good. It's a good sign. It means most people will probably seroconvert, which is true for a lot of diseases. So it's a good sign.
Chris, what are the operating characteristics of that serology test as far as sensitivity and specificity?
Great. So this is if anyone's been reading some of the news in the past week, it's been like when you fall down a wet stairs and you like tumble down the railing and you hit your head on 5 things on the way down. That's what it feels like looking at some of the data coming out of these serology tests. Is that your brain hurts, your face hurts, and you're bleeding from a place that you didn't expect. Is that, or at least that's how I feel when I read them. Is that they just look awful. Like we're seeing sensitivity in the range of, so that is how many times you detect it when you should see it there. Sometimes I've seen one as low as 50%. So like you're missing half the times, the false negative where it's really high. The specificity, which is how many times do you test something, but you actually, get it wrong, and, get a false positive. Some of them seem to be in the 80s and 90% or even 70%. So now that's some of them. To be fair, some of them look really good. There was one, a different company I just saw a headline for that they were seeing above 90% for both, and so it's much more in line with what you'd want to have and related to similar tests. But it sounds like they're all over the map. It sounds like there's tests put on the market that don't have as reliable sensitivity or specificity. So, I know the FDA is looking at this, and there's a lot of EUA. And for people who don't know, it's the emergency use authorization of the FDA, which is during a pandemic or during a crisis, the FDA can put out guidance that says, okay, we know there's a crisis. We need all ideas on the table. We need people to come forward and submit to us tests that you have, molecular methods for quantifying the virus, tracking a virus, tracking an antibody of the virus. Show us what you have. And when the EUA period ends, you then that's the end of your authorization. So you have to resubmit to the FDA once that's over. But it gives you a time during the pandemic to say, hey, I've got a test. I think it works well. I want to submit to the FDA. We're in the middle of finishing one actually at Cornell that has much better sensitivity and specificity than some of the serology tests. But it is an ability to do fast testing with a new method as fast as possible as the EUA. And so some of them have come through that system.
I want to hear about your test that you're working on. But before we do that, could you maybe just give us an idea? I know there's been something like over 70 different serology tests that have been submitted to the FDA for this. Why is it so hard to get consistency? Are they looking at different IgG and IgM antibodies? Is that what it is? Or is it just the method by which they're doing it?
It's both those things. So the Ig or the immunoglobulin antibodies that they're looking for and specific epitopes to the ones being made against the virus is what the sort of the immune system is looking for on the surface of other cells. And it is, there are multiple challenges. When you collect the sample, some of them are done with blood. Other people have tried launching kits with saliva. The methods to purify the antibody that you want to use to detect an epitope that's present in another person, that also has its own set of challenges. You often can do it in rabbits, but you have to basically have a rabbit, basically be immunized and then basically get all the antibodies out of the rabbit. But that depends on which rabbit you use from which facility. So producing antibodies is a notoriously, it's a variable process just because it's you have to purify it, there's always impurities in any biological process. So it's at the antibody side for the test maker. It's at the antibody side for the patient. So some people will seroconvert for a while and they'll make a lot of antibodies, but then it'll trickle down. And this also happens. Most of the audience will be familiar with. You have a vaccine. If you get vaccinated, for some things you have a really long memory. Like, it can actually last almost your whole lifetime, or sometimes your whole lifetime. But in other cases, you need a booster. Like, for example, your tetanus shot, you're supposed to get one every 10 years because the B cells that are producing the antibodies need to be sort of retrained. And so this is a new virus, so we don't really know how fast the immune system gets trained, except it seems to be between 5 to 14 days from the Wolfel paper. But that might be different in other populations. And also, we don't know how long that is maintained in the body. So those are all factors that, we got to give them a little bit of slack because it's a new virus with new antibodies that we know almost nothing about, except for the old SARS virus, which was 15 years ago.
So I want to go back to your specificity answer about the antibodies. So if we're talking about, and just to clarify, if we're talking about IgG antibodies and we're talking about specificity of 80 to 90%, I just want to kind of talk about what that means, because that's really important, because people are talking about return to work. And if we have 80%, to use the lower number, we test 100 people and we say, hey, yeah, thumbs up, you can go back to licking toilets and kissing everyone, you're immune, and you're going to have 20 that were a false positive.
Right.
That's a big deal.
Yeah.
You said some are getting into the 90s now, and then you mentioned a test that you all are coming out with. Was that a serology test, or is that a different test?
It's a diagnostic test. So we're looking, because really for testing, you need to know two things. One is, if someone's been exposed, are they currently likely immune, which is most of the serology tests. But you also want to know still if there is a new breakout or a second wave, how quickly can we test someone? So we've been working on a new test on the viral diagnostic side. So, basically before you have any antibodies, you basically have about a week in your body where you feel really sick and you're shedding virus all over the place. And that's when we built a test that can work in about 30 minutes. It's something called LAMP, which is a loop-mediated isothermal amplification, or LAMP. And it's a protocol. Actually, the original idea was published in the year 2000, and we've been working on ways to actually get it into a very small kit and work very quickly on clinical samples. So we're submitting that very soon for a paper, as well as to the FDA for the validation. And that just makes it so you can quickly get tested. Like one idea, I was just on the phone last night with several different employers, is what if, like every Friday you just get a quick viral test? Because the serology test won't change that much. Assuming you do have antibodies, you probably should have them for a while. But what you want to know is, did someone come in contact with someone they didn't know had it and carried it, and are they suddenly carrying it? And you want to know that maybe once a week we have like an employee happy hour where everyone grabs a beer and they take a quick saliva test, and they get a result back that evening. And then if they're sick, they leave immediately and everyone goes home too. But if everyone's fine, you can stay for the second round or something of drinks, is a concept I was just talking about yesterday. So I think, I don't know if it's going to quite be around the happy hour, but I think something like that might come out to play. And maybe even, I just had a call actually also 2 days ago where people saying maybe companies will view this as just part of their normal corporate responsibility for health and safety. And like, this is what, if you're really a compassionate company and you care about your employees, you have to have something of like this in place, and so that might come to pass.
So with the LAMP test, though, I've been talking to Dr. Bright, our director of infectious disease, about the LAMP test, and it seems extremely promising because it's asynchronous. You can run a large number of samples at a time. It seems like the solution, especially if the operating characteristics are better. But the problem he's been talking about is the buccal swabs and how to actually isolate the RNA. Have you all solved that problem, or are you working?
Yeah, actually, we have really promising data where, you believe it or not, you can just take saliva and put it into saline, and you can lyse the cells well enough so you can break open the cells to get enough of the RNA and DNA out. And it's worked so far on the tests we've run. So I just got an IRB, which is, for the audience, an institutional review board, is basically an agreement to have really ethical and good oversight of our clinical trial and our clinical study. And so in this case, we're beginning to do the collections of the saliva and oral swabs for patients at the hospital, and seeing, can we get the same answer from the nasopharyngeal swab as well as just quickly doing a saliva collection. So and that's that same German group that they did some testing on oral swabs and NP swabs where you have to go through the nose. They did also see that you could get pretty high equivalent viral titer present. So I'm pretty optimistic that we can get cells from the mouth from saliva, lyse those cells, and then that's enough to make the reaction work.
And what were the operating characteristics for that test?
So in that case, we've been seeing it goes down. So we're seeing 94% sensitivity if it's purified RNA, if you take it and go through a normal extraction. And we're seeing right now it's in the mid, like 75% sensitivity if you do it from the mouth. So we're trying some chemistry reagent tweaks to try and make that better. So the problem is that whenever you add a chemical agent that is really good at breaking open cells and destroying, proteins in the cells, it also then inhibits a reaction that's going to come afterwards. So you usually have to either heat something up to disable all the enzymes, and then you could maybe work with it. So we're trying that as a method, or you have to in some way, process out all the proteins, chelate out anything that might be inhibiting a reaction, and then you could proceed. But so we're tweaking with that. We're playing with that right now in lab, actually, as people in lab as we speak, playing with that chemistry.
Chris, there's been a lot of talk about asymptomatic carriers and how there's people out there who basically have no symptoms but can transmit the virus to other people. What's your sense as to whether those people are going to have a positive test or not? Is it possible that you could actually be transmitting the virus to people yet have a negative PCR or a negative LAMP test?
It can. So it is possible, especially in the early days. I think it'd be unlikely for you to be negative on LAMP and negative on RT-PCR, which most people probably know, but that's the reverse transcriptase real-time polymerase chain reaction, which is the way you amplify the RNA into cDNA and then count the copies of virus, which is sensitive down to 5 or 10 or even 3 or 4 copies of the virus, whereas LAMP is sensitive to a few hundred copies of virus, we think. So RT-PCR has been around for 20 years, has been developed for a long time. It's very accurate. But we have interesting patients. So you're not the first one to hear about this. We have people who swear they've got it, and they've been tested 3 or 4 times by RT-PCR, by LAMP, by any method, and they don't seem to have the SARS virus. So then what's interesting is that we've been sequencing a lot of the patient samples to take all the RNA that we can from the nasal swabs and just sequence everything, just see all the fragments of RNA, figure out what's there, and map it to all known organisms. And the really interesting thing is, this is what I was just working on the manuscript before we got on the phone, was, we can see some people who came in for COVID testing because they say, I've got the dry cough, I've got a really high fever, I'm spiking, I feel like I've got it, and the bodega next door, someone there had it, and then my neighbor had it, and I feel like I should have it. So all the reasons in the world to think they have it, but then when we look at them, and by RT-PCR, by LAMP, and even by sequencing, the whole method where you shotgun sequence the RNA, it's called metatranscriptomics, which just means Meta means it's across all kingdoms of life. So it's RNA, it could be bacterial RNA, viral RNA, human, could be fungus, any kind of RNA that's there, you look at it. When we look at those patients with all three of those methods, some of them definitely don't have the virus, but what they do have is influenza. They'll have influenza A. In other cases, they'll have other coronaviruses. Remember, there's actually at least 7 known coronaviruses that are out there. Ones like NL63. There's some other variations of coronaviruses, and we can see some of the patients have them. So not only that, but they'll have one patient we saw had a rhinovirus, a coronavirus, an influenza virus, and SARS-CoV-2. And so you had actually like 4 different respiratory viruses at the same time. So that was an unlucky. In the manuscript I was writing, I said one unfortunate patient carried all these viruses at the same time. So, but there's other people who don't have SARS, but they do have influenza and another coronavirus at the same time. So you can get unlucky and just pick up a whole bunch of viruses and feel pretty awful.
And the testing's accurate enough, obviously, to tell the difference between the different coronaviruses, right?
Yeah, that's actually one really great thing is it used to be really slow and laborious to get specific primers, and you'd only have maybe one test for one virus. There's now, a really good handful of different kinds of tests. So LAMP, for example, RT-PCR, you can just design these little primers, or basically little pieces of Velcro that adhere to one target and pick each one of your viruses. And the shotgun sequencing I mentioned, the metatranscriptome, is we look at all the RNA. So you can see whatever species is present at pretty high abundance or even low abundance, you can pick them all up.
This is a little bit off topic of the testing, but sort of on topic in the sense that we're talking about other coronaviruses. Do you have any idea why SARS-CoV-2 has such a lower mortality rate or case fatality rate than CoV-1? It seems like the spike protein is actually more efficient for CoV-2, which is probably why it's more transmissible. But is there any sense as to why there's a difference in the case fatality rate that's so drastic?
Yeah, very much so. So I think if you had asked me, 2 weeks ago, I would have said, well, maybe variations. But now I can tell you almost certainly variations, genetic variations in the virus itself. So when we've been sequencing all these viruses, you get the actual genetic code and the makeup of each virus. We can see deletions present in SARS-CoV-2, which are different from SARS-CoV-1, which was the original SARS virus that was much more lethal. It's carrying a good number of deletions in genes. What's one's called the non-structural protein NSP1, which is basically some of these sort of other variants in the genome that have already been associated with essentially how the virus replicates and can attenuate how fast it replicates. So what we think is that this genome, just by luck of the draw in evolution, picked up some mutations that make it a little bit less able to replicate quite as fast. And so that data is only a few days old. But what's interesting is what's actually amazing about this time is we sequenced our patients, and I was able to tell within 12 hours. I was able to download and pull all the other viral sequences in the world, compare it, and look for these other deletions, and we could validate it very quickly and say, aha, we're seeing this in other patients. Now, what's interesting is we don't see it in everyone, so I don't yet have an answer. That's what we're working on right now, is to see, is there some consistent mutation that is always there, and there is a reference genome that is pretty different, where it overall carries more deletions. It's missing chunks of the genome relative to SARS-CoV-1, but we do see some subtle variation in other patients, and so that's what we're looking at right now. Is, for example, there were 2 strains that were talked about, the L and the S strain, that were potentially more virulent in the early days of the epidemic, and we do see differences in New York, just like they did in Wuhan, but it's not clear that it's tracking yet with severity. So, but there are some substrains that are there we can see.
That was actually my next question. Are there any substrains that we think are going to be more virulent or that we need to worry about more?
So we're just, so I think, at least from the Wuhan data, they noted this L strain, which really just defined by a small SNP, a single letter difference. That's all it is. But it defined these 2 clades, or these 2 groups of the virus that were really early on separating out. The challenge with that is they could just separate because it was just by chance, like maybe the way different people interacted is just how they, as a matter of just accident and how the virus moved around. But they predicted in Wuhan that the L strain was more virulent and seemed to be more aggressive, and they saw it in 70% of the population there. In New York City, when we've looked, we've seen in about 90% of the patients carried the L strain, at least from the patients in middle and early March. And so there are different. It does seem to be enriched for that strain, but it's too early to tell. We're basically in the process of merging all the strain level data with all the patient clinical data. I actually just submitted paperwork on that this morning. So to ask that exact question of, given a certain mutation in this virus and the clinical data, how much do they match? And I think we'll know that in the next few weeks, because we're taking all of our data. The goal is to make as much of it public that we can, and combine it with other data sets to ask that question. And so far, I don't think so, based on the literature I've seen. But for our own data, we have the strain mapping, and now we're getting the clinical data, and we're putting those two together.
Sorry to go back to testing, Chris, but got several questions about the testing. I'm kind of obsessed with these numbers right now, just because we have to understand them to make good decisions going forward. So with the LAMP test specifically, you mentioned a 94% sensitivity number. So the first question I have about that is how do you even calculate that? What is the gold standard that you're comparing against? Because I thought the RT-PCR was kind of the gold standard, and it's a lower sensitivity. So how do you get to that number first?
We're comparing it to RT-PCR. It is currently basically the best gold standard to compare. In technology and testing, there's really no such thing as a true gold standard. The only way you could have that is if you synthesized every molecule that you knew was in a cell, and you perfectly lysed that cell, and then you were able to capture everything out of it. So we don't yet have that ability to make a true perfect gold standard, but RT-PCR is what we're comparing that against. And it is, but RT-PCR is above 99% specificity, and usually above 97 or 98% sensitivity. So it's supposed to be, at least from our own data, from our own submission to the FDA at Cornell, it is on that level in terms of its sensitivity and specificity. Now, it doesn't mean it's perfect. Nothing's 100%. Well, because really, I guess nothing in the world is 100%, except maybe death and taxes. But beyond those two things, there's no guarantee. And I think, so but we've also seen it depends a little bit on how you collect the sample. So some people get much lower mileage out of their test because there's contaminants in the kits that they ordered, or there's, collection problems where someone does the nasopharyngeal swab, but they don't do it deep enough, right? So embedded in that error rate is all the challenges of getting a sample that you have to account for. So that's another part of the reason you never get to 100%. But are you curious about, if our sensitivity is never perfect, how are we worried someone's not a false negative?
No, not really. I mean, that's obviously, we just have to assume that. We should have to know what the risk of that is. I guess I was a little confused about the RT-PCR. I thought the sensitivity on that was lower. There was a higher false negative, lower sensitivity coming out of most data. Is that not true?
So from the EUA submissions, it's not what's been posted. There has been, however, one paper that suggested that RT-PCR was missing 30% of the cases. You might be referring to this paper, just came out about 9 or 10 days ago. It was comparing some nanopore sequence data against sequencing methods to RT-PCR, saying that it is actually, missing that many cases. And so from our own work, though, I think it might be as much as maybe 5%, maybe at most 10%, but we've seen more like 3 to 4%, where sometimes you can use sequencing to get deeper and catch the viruses that are really low abundance. But I think RT-PCR, I mean, again, it's been built off 2 decades of work and optimization, and as long as you have good primers, it works really well. There are other tests, though. It's like any set of Velcro pieces. If you're trying to attach and amplify one piece of RNA, and you didn't pick the good spots to amplify, you'll get a much worse sensitivity. That's one component. The other one is the viruses don't replicate as one sort of single piece. They have what are called subgenomic regions, and then the entire viral sequence, and different parts of that genome are represented in cells at different abundance. And so you often want to design your primers at the spot where you have the best chance of catching the virus, and not everyone has done that. So I think, anything you might see when someone says RT-PCR, it really depends on, well, who made the test, which primers did they use, what kind of samples did they test it on. Those are all factors. And that's why you can see anything from, we have a 97 and 98% sensitivity down to 70, 75% sensitivity. You'll see everything in that range.
What do you know about the Abbott machines and the Cepheid machines, about the operating characteristics of those?
Yeah, those look, I've heard mixed reviews. We do not have one directly, so I don't have any firsthand knowledge, but I've seen a bit of literature review on this. And it uses actually a similar concept of what we did with LAMP, which is an isothermal amplification, where you do it at one temperature, and then within 15 to 20 minutes you can get a result pretty quickly. Chemically, what happens is basically it's a reverse transcriptase that's called warm start, which means it works at 65 degrees instead of a higher temperature Celsius. And then once it starts making copies of RNA into cDNA, there's something called the BST polymerase that quickly makes copies of that DNA. I mean, by quickly, I mean like very immediately you get large structures of DNA. And if you let it go long enough, you can take water that looks like, very mobile and regular water. It starts to get, clumpy, almost like syrup, because so much DNA is being made. So the reaction runs really fast. It's kind of like 20 years ago, they would measure the output of the reaction by the turbidity of the solution, like how syrupy did it get, and it was just making DNA, which almost sounds like a horror movie. Like the reaction's it's going endlessly, it's going to take over the entire room, but you'd have to have enough DNTPs or chemicals in there to make that possible, which wouldn't happen. But it is a really fast reaction, so that's what the Abbott test is using. And it is, but what's great about it is it's really fast, but it can only run one sample at a time. And the estimate of its sensitivity, I just saw some estimates that maybe it's 80 or 85% sensitive, so it might not be. But these are things I've seen, and I want to get really good empirical data over hundreds of samples before I'd make any strong opinion about it. But I think as a point of care diagnostic where you can quickly grab it, get a sample, get an answer, it's great. It's not good if you have 500 employees waiting to get tested, because you'd need several hundred machines to get it done in a reasonable amount of time. But it is it's good. And the Cepheid also looks good, but we haven't looked at that one as closely yet. It just came out.
I mean, the lamp really seems like the way to go in the future, just the asynchronous nature and how much you can do at a time and the sensitivity. What is the rate limiting step? What is going to be the problem? Is there an issue with getting reagents? Is there extraction? What is the issue?
No, not too. We've been working with, it's really just about making it automated. So when we ran into it, we did a full CLIA lab run through last week. And they, it looked really cool. It's a great technology, but it's very manual, right? We have to use our hands and pipettes to put things into plates and then run the reaction. Where if you compare it to like the Roche Cobas machine or some of the other, or even the Abbott machine, what CLIA labs like and general diagnostic labs everywhere like is, I want something where you put the sample in, you don't have to do anything, and at the end you get a result, because the less hands-on any process, the less chance of any error. So we're very excited. Everyone's excited about the idea, but now we're working on the automation of it. The scaling of it's not so much a problem, because we can do it on plates. You can do it in larger plates, but we still have to work on that scale automation step. But so the automation at scale is the second thing, and then just making the chemistry, more robust to, shipping conditions or any contaminants. And so that's why we're testing on saliva now, because I think most of our testing has been on purified RNA, which is kind of an easy target. But we want to really make sure it works on nasal swab, saliva collections, really any part of your body potentially. It could even be a fecal collection. There's been virus seen there. Interestingly, there has not been coronavirus seen in urine yet, but you could also imagine someday if there was, something that could be found in urine, you could look for it that way, kind of like a pregnancy test. But right now, there's no evidence of the virus in urine. So that's what we're very excited about as well, because it's simple, it's fast. I actually think what I like the most about it is I think anyone could do it at home. I mean, our long-term goal, the near term is the CLIA lab, at Cornell, and getting it up and running, getting it in with the FDA. The middle term is to get sort of pop-up labs where anyone could do it, maybe for, employers or like a Walgreens or different places around New York City. But, I'm hoping 2 or 3 months from now, there's not just 1 or 2, but maybe 3, 4 different home testing solutions. And a lot of them are based on the LAMP chemistry. So the Abbott system our LAMP chemistry is. You may have also heard about, there's 2 other companies. I have no financial relationship with them. I just think they're interesting. Is Mammoth Biosciences, it is basically out in California, and there's Sherlock out of Harvard. Both of them use a CRISPR-Cas9 system where you basically have a small guide RNA that if it sees the virus, it starts to cut the virus, and that changes how you can actually have some of the LAMP chemistry basically embedded on the paper, where the color changes basically because the virus has been detected. And there's 2 different groups trying that. So you could imagine, hopefully by the summertime, there's options where you could get a little home testing kit on various viruses you want to see if you've got them. We've talked about this a bit, like, at Longevity, where that's a company we have in New York of saying, well, can we get more and more testing democratized? And we started a lot with, microbiome testing, genome sequencing, metabolomics, but I think in the long run, I think there'll be more and more of this democratization where you could test things at home and just make it easy and convenient.
Yeah, Taylor talked about doing it in the back of a truck. They've done it for agricultural uses
Which is great, because if you're in the truck, then you've got everything you need. You got a power source. You got, you just need basically you just need a table, and some pipettes and some reagents, and that's it. And then you could get the kegerator in the corner, so you got your cold beer. Maybe you could get that in there. It's all possible.
I think what all of us are kind of talking about is this concept of testing because we're all sort of like seeing the light at the end of the tunnel, and we're starting to think about, okay, when are we going to open back up? How are we going to open back up? And I think we all probably on this call at least agree that testing is a giant portion of how that's going to happen. What thoughts do you have, Chris, on how we might see society opening back up to some degree?
Yeah, I'm hopeful it'll happen really in the summertime. It is a bit painful to not have it be in the spring and be outdoors just as the winter thaw happens, but I think it'll be soon. I think it will be really a combination of the testing, really common testing that's cheap and easy, and then also some of the consistent surveillance and say, well, if someone does test positive, how do we react to that, and do some isolation, and then continue the surveillance and make sure that people just can, I think you want to make it so it's really easy to know, have I been exposed? Am I safe to go back to work? It's the serology testing and then the virology testing. Do you have the virus? Or have you had the virus? And if you keep doing both those things, and maybe you do it every Friday at the happy hour, like I was saying, maybe you do it, Monday morning when you get in, or another option I was talking about, just a concept is Friday, everyone who leaves work, they get a little kit, and they go home and they do their test at home, and then they come back to work on Monday as long as it's a positive, or it's a thumbs up for they're clean, and if they're not, then they can stay home for another couple weeks or something. So you could imagine, if we can get the test that ubiquitous and that cheap, I think that'll help. But it's really the testing, both the virology and serology testing, and then active surveillance, and then whenever someone's positive, get just isolation, because that's how we're going to prevent that second wave. But it's still unknown if this is just going to become like the flu again, where it goes up and down the hemispheres every year. Is it going to just be a second wave and then it goes away? We don't know. There's an active debate about this. Some people think it's already a foregone conclusion, like it's just going to be the new kind of flu. Other people think it's still possible to squash it. And so I think I actually had this really interesting discussion with my wife. She was saying, well, she said, if everyone just stays home and doesn't go out, the virus would go away. Right? Like if everyone really stuck to it and didn't leave their house for, say, 3 weeks, they would go away, right? And the host would essentially, everyone would seroconvert. There wouldn't be enough virus to transmit. And then she said, well, why don't we do that for the flu? And I said, well, it's just at a socially tolerable amount of infection and death, whereas if this one just is not, right? So, but interestingly, if everyone in the world just promised to not leave for multiple weeks, we would squash almost all infectious diseases that exist, right? Because, well, at least a lot of the viral ones, right? So it's interesting to think about what could you do if you forced everyone to stay in their house for a few weeks.
Unless we gave this one to our dogs and then they gave it back to us.
So that's the other thing. Yeah, the Bronx Zoo, I think, as many of your listeners know, the zoo had the animals, the tigers at the Bronx Zoo. Multiple tigers had virus. So I think there was a moment where anyone who has a cat in their house took a look at their cat out of the side of their eye and said, well, so there's some, and all dog owners are like, yay, but there's been one dog that's been seen to have it. So there is a continual exchange of organisms, microbes, and viruses between, all of life on this planet. So it's not shocking that it happened. It's just one of those moments of, maybe it wasn't just the bats or the pangolins that were the problem. Maybe it was some feline sort of sources too. So it's everywhere.
Well, the other option, we could do a combination of isolation and herd immunity. I was talking to somebody this morning. I said, why don't we just send everyone under 40 who's not obese, doesn't have asthma, no risk factors, to Cancun, the entire nation under 40, let it rock. Then we've got like a massive set of immunity, and then everybody else that's over that age stays home for a month.
That's great. We'll call it a music festival called Fire. What do you think?
Yeah,
that's
Fire
right.
Festival.
Coronavirus. That's right.
Coronavirus.
So, Chris, sorry, I know we're taking a lot of your time. One more kind of hypothetical question that is not fair to ask you, but I'm going to ask you anyway. So, let's say somebody wants to get together 1,000 people. We're answering this question. We're talking about this now for in the future. It's not the time yet. But when we get to that point, assuming we have robust testing, the LAMP or RT-PCR, we can do serology testing. We can quarantine and isolate in a limited area. We're talking about a sporting event or some other sort of event like that. What do you think is going to be the biggest fail point? Because there are human factors, there's testing, there's multiple components to that. What do you see as the biggest challenge to doing that several months from now when we think maybe we're ready?
You mean it's going to be any large gathering? It really runs the risk, and so I think you mentioned sporting events. It is, the Olympics, of course, were moved back a year because of this concern. And what's interesting is from the people I've talked to on the White House task force, they're not so concerned about the near term because for example, New York City, it's bad, but now it's peaked and it's starting to go down. But then it's just going to basically, the worry is that these peaks are just going to shift around, and that you'll get something that might be a late peak that happened because someone got together in a big crowd like 5 months from now. And so one of the best analogies, just think about like a brush fire. We have one really big fire, but these tiny little embers will go around and make smaller fires, and they won't kill as many people, but be as bad, but they'll still be bad, right? So I think the only way, like how do you engineer herd immunity? And this is something that Boris Johnson kind of alluded to, saying, well, maybe we'll think about this, because eventually it can happen, but you normally need to have at least 80% of the people that have some immunity before you can get close to it, based on most estimates. So. Unfortunately, we're a ways off. It's going to be, in even the Cancun idea, like if you send everyone there, statistically most people would be okay, but there'd still be 0.1% of people, 0.5% maybe, that would get really sick and die, even if they're young. So I think it's one of these viruses that is a little too easy to catch and a little too deadly, based on what we know. And I think unfortunately, it just takes time in the sense of herd immunity. But there are also people, there's been some studies on using zinc or using other methods to think about what can I do from a prophylactic method to say, can I try and think of ways to prevent it? There's no good randomized large-scale trials, so I can't recommend anything here. But the thing that's more interesting, I think, than just a prophylactic from a chemical or antibody perspective, or convalescent therapies, we've talked about that. I think it's even more interesting is we can see who has a lot of the ACE2 receptor active in their cells. We can actually see it in the clinical data. Maybe we could think about ways to tell people if they're high risk or low risk, right, based on their expression profile of the cells, in their airway. Because you can see people that have a lot of the virus have a lot of the ACE2 receptor present. And so, a lot of people think, well, can we think of things that block it potentially or change the receptor? So I think, while we wait for herd immunity, we don't have to sit idle. We can keep thinking about these ways to block it from entry, or activate some of the host defenses, and make it so you can have a better chance when you do see it.
So you don't like my Cancun
idea? No, it would work though. You'd have to have a certain amount of tolerance for.
You can do Cabo or Miami if you think that's a better idea.
Or you could wrap everyone in plastic, and then I think I love the idea, but it's like anything in medicine. If you can inform an idea with a way to stratify a little bit more granular as to who's at high risk and low risk, and then because it'd be perfect if we could say, listen, we have a 99.999% chance that all these people that we've molecularly tested, you'll be sure to seroconvert and get immune, and then that risk is it's even better than the flu, right? So then that'd be fine. But it's just we currently just can't stratify people yet, but I'm sure we will soon.
It'd be a great way it'd be great if we could just basically say, you have this percentage of ACE2 enzyme in your tissue of your lung, for example, or, or even if it's just like even if it just starts with genomics, and we can say that, certain these people have this SNP and therefore have a higher expression of ACE2. I mean, that would be phenomenal.
And that's ongoing. because there's multiple sort of COVID host genetics initiatives. One's at Rockefeller, one's at New York Genome Center. There's multiple, a lot of them in New York, but there's one at Stanford, one at UCSF. So a lot of geneticists are sitting at home with nothing to do and thinking, I wonder if I could study this. The biggest example is the HIV mutation called CCR5, where a patient in Berlin was carrying high levels of the virus, but the virus was in his body, but it couldn't get into any of his T cells. And so could we look for people that are resistant or superheroes in that way and learn from them? Because you can learn from them therapeutically, like what could we target? And then also, if you could somehow transfer that sort of superpower to other people in some ways, that would also be pretty amazing. That gets more into synthetic biology and like artificial chromosomes and artificial receptors. And that's maybe a topic for a different podcast, but you can imagine at least looking for those patients to learn from them.
Perfect. So for that podcast, we'll plan on next week, same time, or?
That's right. And we'll have the heavily engineered human beings that are resistant to all viruses. Should be done by then, no problem.
Yeah, I'll see you down in Cancun, Chris. Thanks for your time, man. I know you've got a call here in just a few minutes, so I'm gonna let you run. But we really appreciate you coming back on the podcast and talking with us a little bit more about this stuff. Your knowledge and interpretation of the data is invaluable. Thanks.
Great. Thanks so much. Pleasure to be here.
Thanks, Chris. And just for clarification, Mike's not under 40, so he wouldn't be in Cancun. So.
Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at Wild Health MD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.